is important because the epicardial pathways are easily diagnosed. If you have a QS pattern, complete QS pattern will lead to, and if you have a reverse pattern, like you're even sure of an MCV. But that's on the ECGs which you can read about. So I like to concentrate on some more specific features. So this is an ART, because having a P wave so well, and you have a RP which is more than 70, 90 differentiation, which is a very, very important feature. Very, very important feature. Important is that ST depression does take place in these tachycardias in AV RT. Like in AV RT, you should remember pseudo S, pseudo R. In AV ST depression, it tends to set in. Important feature, why this happens? Because you have a P wave, it tends to cause the ST segment depression. So ST segment changes, RP which is visible, you have a P wave which is visible, more than 2 small squares, all clues towards AVRT. Another clue, QRS alterance. So if you have a QRS alterance, again a feature that will help you focus on AVRT. AVRT, pseudo S, pseudo R, AVRT, ST segment changes, retropees which you are able to appreciate at 90, even sometimes QRS alterance. So compared to the long QRS tachycardias, if you go to long QRS tachycardias, long RP tachycardias, it is basically non-AT. Either you'll have EAT, as we said, atrial tachycardia, atypical AV or a PGRT. Very, very important feature. You see a RP which is long, but see the RP-PR ratio. That means the more the P wave is towards the QRS, and if the P wave ratio is more than 6, because which says this is a differentiating factor towards EAT. So if you have a long RP, you can still have AVRT, PGRT, EAT. Try to look for this feature, a P wave duration more than 96. And of course, all these tachycardias will have negative P waves in inferior lead except atrial tachycardias which can have a positive P wave also. So an atrial tachycardia, important feature. You have a RP interval which can be variable, an RP which is greater than PR, which is a very basic thing. But the RP variable interval which is variable, more than 1.65. Important features help you differentiate between EAT and the other two, PGRT, atypical AVRT. Localization of atrial tachycardia is very small. In a very short, I like to tell, right-sided pathways, you will have lead V1, which can be negative, positive, negative, or negative. And AVL, which can be real positive or positive, negative. While for our left side, there are again very good algorithms, but this is a grossly way of identifying, because there we are trying to know there is an atrial tachycardia. And localizing it is a different picture. If it's on the left side, you will have a lead one, even which is positive or negative positive, and an AVL which can be negative or neutral. Of course, 2-3 AVL positive, superior, 2-3 AVL negative, inferior side. So this is a young male tachycardia. Of course, this was marked as EAT, but you can appreciate that there are P waves which are much more. This can even easily be an atrial flutter. So the atrial flutter will always remain an ED in such a case. Let's say you have such a tachycardia, and this is again a case of a typical Krista EAT, where you have an ECG which is almost like a normal ECG, and you have an AVR which is negative, characteristically AVR which is negative, and see if you see the catheter position, this has been ablated very near to the crest. So the same thing, let's say you have a long RP, so your DDs are same. I said there is a RP which can help, but then your DDs are still same. If you have a person which is young, talks about an incessant tachycardia, very important part of history, and you have LV dysfunction, you can again think of PGRT. Of course, you have a 2-3 AV which is negative. So your atypical and RT PGRT stay, this being long, severe LV dysfunction points towards PGRT. Atypical AV and RT, as we all know, this is going to have an RP which is long, because now instead of the basic way of going down from slow and coming back from fast, you have going back from slow also. So you're going to have an RP which is long. Example of a atypical AV and RT, will you have an RP which is longer? Again, I said this is going to be very thin line between a PGRT and an AV and RT. The basic things which can help you is the longer is LV dysfunction, age. Some of these factors can help. That is why history I said is important. It's just an example of a sinus tachycardia. One of the features, one of the things to be seen in a long RP tachycardia. So there are some SVT discriminant maneuvers which you can do. Vagal maneuvers. You can, the Valsalva, carotid, or dipping face into cold water. These are the things which you can have. AV nodal re-entry tachycardia or a AV RT which uses the AV node, because they are going to tend to block the AV node. You will have a breakage of these tachycardias. While an atrial tachycardia, see the EGMs. While an atrial tachycardia, the atrial rate will continue, because you're blocking the AV node, you can't block the atrial. So say same will happen in atrial flutter. So very important, very easily help you differentiate AVRT and atrial tachycardia. Carotid massage in a EAT will have the same effect. Your tachycardia continues, your P wave continues, whether you have a decrease in the rate, ventricular rate. So important, very important slide. First thing, AV blocks. If AV block is there, you are practically excluded in AVRT. QRS alterance, common in AVRT, but can be seen in AVLRT also because it's a rate dependent phenomena. And practically AVRTs have a higher rate, so more in AVRTs. P wave localization, as I said, RP variation is an important thing in EAT. Again, as close possible, more likely AVRT, intermediate AVRT, longer EAT. In EAT, you can still have 2-3 AVF which can be positive. P wave bit, again variable, but again aberrancy more common with AVRT because the rates are higher. So functional aberrancies can come in. Clues from termination. So these are all the way of looking at the ECG. If you have an ECG which shows the termination, so if it terminates with a retrograde P wave, so practically overruled AVRT, AVNRT and a PGRT. Very, very important thing. But if it terminates without, so you are able to overrule any EAT, something which you can overrule. And so while if it doesn't, if it terminates without a P, you can mostly have an ectopic, but still anything can be there. So the first one is more of a heart phenomena. That if you're terminating with a retrograde P wave, then that means you have practically overruled a EAT. Now for the irregular ones, as you know, you will have irregular P waves in a patient with atrial fibrillation or a flutter. Now this is a circuit of a typical atrial flutter, as you will understand. It's going to go counterclockwise. You're going to have a V1 which is positive and a 2-3 wave which is negative. As you all know, the flutter requires boundaries and a rate of around cycle length of 200 to 60. Flutter is mostly counterclockwise, can occur at atypical flutter also, it can be clockwise, but I'm tending to concentrate on the typical ones. So the ECG is typical to sawtooth pattern. You can have a variable block. Mostly it's an even block, but it can be an odd block also. 2:1, 4:1 is more common. 2:1 flutter, atrial flutter can look like a science rhythm. So it's very, very important that we tend to take a faster rate and tend to see the P waves more easily. An atypical atrial flutter, once again, it will have the other pattern. You have more P waves, but you will see the V1 which is negative and 2-3 wave which are positive. Multifocal atrial flutter tachycardia. This is just to show the very morphology which is there. More than 3 P wave morphologies you can appreciate in ECG. An atrial fibrillation where you can't basically appreciate the P wave at all. It's a common phenomenon which we see. Now, this is an important thing. Final ECG, this is an ECG which is very, very common, and since we were talking about supraventricular, so I just wanted to keep this 35-year army Jawan. If you have anxiety, perspiration, and you have a fast, broad, irregular tachycardia. It's fast, broad, irregular. Every beat, the axis and the motion is changing. So what is to be done in this case? This is a fast, broad, irregular tachycardia. I've shown you this previous also. Dr. Deva, please mute yourself. Yes, Sanjeev.